Hello, I'm going over etiology and a little bit of everything to do with traumatic brain injuries. So, traumatic brain injuries, it's an insult to the brain. It's not due to degeneration or congenital nature, but it's an external force that was applied to the brain that may produce an diminished or altered state of consciousness, which results in impaired cognitive abilities and then also impaired physical functioning. On top of that, a lot of TBIs could be a result of impact injuries, penetration wounds, and shear injuries, depending on acceleration or deceleration. And they can be traumatic brain injuries. Some can be temporary, acute swelling, and then once it recedes, you can go back to normal functioning, or some can be permanent and cause permanent brain damage. And examples would be like subdural hematoma, subarachnoid hemorrhage, and epidural hemorrhage. Going a little bit more into it, causes of traumatic brain injuries, the most common causes, the main most common causes, motor vehicle accidents, and then unintentional falls, unintentionally being struck by an object, then an unintentional injury, unspecified. Next is intentional self-harm, assault, and then the last one is any other mechanism that was unspecified. So now going over the relative anatomy and pathophysiology of traumatic brain injury. So you have pretty much like two parts to traumatic brain injury. You have the primary injury and then secondary injury. Primary is a result of the impact or trauma that caused the injury in the first place. Result of brain tissue coming in contact with an object, or very rapid acceleration or deceleration of the brain, which can cause contusions, lacerations, or intracerebral hematomas. Acceleration and deceleration injuries can cause shear, tensile, and compression forces on the brain tissue. These usually cause diffuse axonal injuries. It's the main mechanism where you have a bunch of microscopic tears in the axonal and this is an example of Wallerine type axonal degeneration. You have some tissue tearing, hematomas, a lot of buildup of the CSF fluid or blood in the different dural spaces, epidural, subdural, intracerebral. Blast injuries usually cause a mechanism of the war. You don't just see that every day. And then secondary injury are things that happen due to the primary injury or after the primary injury, which would be like increased intracranial pressure due to inflammation, swelling, cerebral hypoxia or ischemia due to rupture of blood vessels, not able to get the blood to that area, post-traumatic intracranial hematoma, intracranial hemorrhage, also could be due to rupturing of blood vessels, and increased intracranial pressure, electrolyte imbalance, acid-base imbalance, infection due to open wounds, and then also seizures due to pressure or scarring as well of that brain tissue. So now that we know like the pathophysiology and the anatomy-wise of the TBIs, it all depends on where the traumatic brain injury happens. Each lobe has its own job in each part of the brain. So if you have an injury to the frontal lobe, then you have a lot of problems with behavior and cognition, reasoning, sequencing of movements, and motor control in general. You could also have some problems with memory, working memory, and with the emotional support and cognition, things like that. And continue on from anatomy and physiology of a TBI, also kind of moving into the clinical presentation along with that. So depending on where the traumatic brain injury affected, whether diffuse or focal, different areas of the brain, whether frontal lobe, parietal, temporal, insular, occipital, basal ganglia, whether it was some of the axonal pathways, some of the nuclei or brainstem, they'll all present differently, and those are the clinical signs and presentations that physical therapists will usually be working with and dealing with. So clinical presentation based on the anatomy where the traumatic brain injury affected the anatomy, physiology of that person. They could present with neuromuscular signs like paresis, abnormal tone, motor function disorders, and postural control dysfunction. They could present with some, this next one has a lot to do with either brainstem, the limbic system, or frontal lobe. They could present with arousal level problems, attention problems, concentration, memory, and learning problems, as well as executive function problems. Next would be more limbic. This would be neurobehavioral stuff like agitation, aggression, disinhibition, apathy, emotional liability, mental inflexibility, impulsivity, and irritability. And then they could also have communication and swallowing affected if parts of more the temporal and parietal lobes were affected on top of some of the frontal lobes. From there, diagnosis of a TBI, the most common way of diagnosis is through CT scan and MRI, but you can use other things as well, like cerebral angiography, radioisotope imaging, and ventriculopathy, encephalophagy, EEG, monitoring intracranial pressure, cerebral blood flow, metabolism, cardiorespiratory and cardiovascular function, CSF and biomedical studies, as well as visual, auditory, and somatosensory evoked potentials. The most common was CT scan, and those can identify hematomas, ventricular enlargement, atrophy, and lack of results from a CT scan does not mean that there's not extensive brain damage. Another test might pick something else up, like for instance, MRI provides superior soft tissue discrimination, and so MRI is better for picking up lesions resulting after a traumatic brain injury. From there, we look at prognosis. So prognosis can be affected by a lot of factors, like age. The older you are, the poorer your prognosis is as far as recovering from a traumatic brain injury. If you have a presence of intracranial hematomas or subdural hematomas, you have morbidity and mortality increases, so poor prognosis. A presence of decorticate or decerebrate posturing, or if you do not have a response to noxious stimuli, that increases mortality rate and lowers prognosis. Brainstem signs like papillary abnormalities and abnormal eye movements can affect that as well. And if the intracranial pressure is outside of 20 and 40, between 20 to 40 millimeters of mercury, might have severe residual disabilities and also lower prognosis. Severe increases or decreases in intracranial pressure can cause perfusion, hypoxia, and increased cerebral edema, which accounts for about 50% of deaths for those with traumatic brain injury. Moving forward, we talk about Glasgow Coma Scale later, but mentioning it a little bit now as far as prognosis. The Glasgow Coma Scale is good as far as rating prognosis of a patient, because if a patient scores above 12 on a Glasgow Coma Scale, they have a really mild TBI, and they will have not really that many deficits 3 months post the traumatic brain injury. If they score between 9 and 12, they have a moderate TBI, and it's cut off for comatose patients right there. And then if they score less than 8 on the Glasgow Coma Scale for longer than 6 hours post the injury, then this indicates a very severe injury, and 90% of those patients are comatose, and unfortunately about 50% of them do pass away. Another scale to rate or score as far as looking at prognosis of the patient is post-traumatic amnesia scale, which looks at how long after the injury do they have loss of consciousness, arousal, or memory, mainly memory at that point. If it's less than 10 minutes, then it's very mild. Less than an hour, then it's mild. If they don't remember stuff for 1 to 24 hours, is a moderate injury. 1 to 7 days is severe, and longer than 7 days is very severe. From there, we're looking at medications for those with traumatic brain injury. So there's not a medication to fix a traumatic brain injury. There's medications to fix a lot of the signs and symptoms that are due to a traumatic brain injury. So things, you'll take medications to decrease intracranial pressure, to control blood pressure, treat the physiological injury, however the traumatic brain injury happens, drugs that affect the motor, behavioral, and cognitive functions, especially due to the secondary sequelae of the traumatic brain injury. Example of some of these motor, behavioral, and cognitive function problems would be like spasticity, hemiparesis, vision changes, balance, vestibular problems, apraxia, ataxia, agitation, confusion, and etc. Things like that. Moving forward, so as far as surgery goes with traumatic brain injuries, if you have a closed traumatic brain injury, you do surgery to decompress the injury, prevent shift of midline structures and damage to areas that weren't initially affected. For an open traumatic brain injury, you'll do surgery to remove debris, clean the wound, and restore normal contour of the skull. And from there, we have a video talking about the outcome assessment measures and treatment for TBI coming up.
Hello, I'm going over TBIs, and for traumatic brain injuries, we have a lot of different stages and a lot of cognitive function and motor function, as well as emotional and other things that are affected by TBI. So there's a lot of scales that are used to score acute stage, active stage, and post-recovery, getting out of the hospital or getting out of an inpatient unit, for the different levels for TBI, since every TBI is different. So starting off with the acute stage, you're really going for trying to see like what level of consciousness they have. So the scales that they have for the acute stage are more like the coma recovery scale that's revised, the disorder of consciousness scale, and the Ranch-Los-Amigos level of cognitive function, which is one of the main ones that are used for TBI, just trying to see are they even able to react to stimulus. If they are able to react to stimulus, how confused or agitated are they? And from there, as they progress, how long can you keep their attention and keep them doing something, and what level can you talk or correct or work with them where they actually understand you. Because you're dealing with brain injuries, you have a lot of cognitive deficits that come with this. When you move to the active recovery or the rehabilitation stage, some of the tests that we have here, you have your balance section, which would be like the Berg Balance Scale, the Community Balance and Mobility Scale, the HEVA mat, or the HIMAT, the High Level Mobility Assessment Tool. And then you can also assess attention and cognition, because cognition is also going to be a huge part to play in this, because depending on where the traumatic brain injury happened and what all areas of the brain it affected. So those would look at the Moss Attention Rating Scale, which is the MARS, the Galveston Orientation and Amnesia Test, the GOAT, and the Orientation Log, the O-Log. You also have behavior and safety scales, which are testing really functioning of the limbic and the frontal lobe as far as behavioral safety and cognition, as far as like, are they able to make correct behaviors and judgments and have proper reasoning skills. They look at supervision rating scale, the neurobehavioral rating scale that's revised, and then from there we have global functioning scales, functional assessment scales, community reintegration scales, and locomotion scales. So there's tons of scales for TBIs, just looking at overall anything from ambulation to balance to cognition to ability to looking at spasticity or anything like that. So really we can use almost every scale out there in trying to assess what level they're at. And there's a lot that are tailored to specific points in time of their retreatment and specific points of their recovery, whether it's cognition, motor, or something else. From that, I would like to review a couple of the ones that we definitely went over for TBI, be used by a physical therapist for sure, would be like the Ranch-Los-Amigos scale, which would be in the acute and somewhat in the rehabilitation stage, as well as the Glasgow Coma Scale. So going over the Glasgow Coma Scale, which is really used in acute phase right after TBI, depending on what level of cognition or how bad the TBI was. the glaucoma scale looks at 3 domains: eye-opening, verbal response, and motor response due to different stimuli. Eye-opening, you want to see if it's spontaneous. So whatever response, whether pain or verbal stimulation or something like that, if they just open their eyes spontaneously, or if it's open to somebody's voice, or if they open their eyes to pain, or if they just do not open their eyes at all. So the next is verbal response. So depending on whatever stimulus that we provide, do they stay silent throughout? Do they make incomprehensible sounds like grunting or something like that due to, let's say, pain stimulus or talking to them? Do they respond by saying inappropriate words? Do they respond but sound confused, or are they completely orientated and can have a conversation with you? And then motor response is also looking at, do they have like abnormal extension away from or towards the response, abnormal flexion? Do they withdraw from, let's say, a painful stimulus or some type of tactile stimulation or voice? Do they localize, like do they move one extremity to the other as far as localizing where they're having pain? And then next is, can they obey commands, move their body where you want them to when you ask them to? So the glaucoma scale is scored from 3 to 15. If you're at a 15, you're fine. If you're 3, you're in a very deep coma. The next one they look at would be functional independent measures, the FIM. This just rates patients based on their level of assistance. 1 is total assistance and 7 is independent. So you go from total to max, moderate, min, supervision assistance, and then modified independent, and last is independent. And then the last scale I'd like to go over is the Ranchlos Amigos brain injury scale. So for this one, definitely used for traumatic brain injuries, just because a lot of traumatic brain injuries actually follow this scale as far as their treatment progress. The first one on the scale is no response. So no response usually for traumatic brain injuries at very acute stage where they're either in a coma or just not responsive to touch, sound, pain, movement, anything like that. So no response at all. The next one would be generalized response. So they begin to start responding to some stimuli, but and then they might be like, you could see changes in their breathing or chewing, or they might moan or something like that, making some sounds and responding to stimulus, but not necessarily responding to stimulus properly and each time. We go from there through the other scales. The next one is localized response. So that's when you do a stimulus and they can localize to it, move that other hand over here. Let's say I were to pinch, she would actually localize it where that pain is. And then once they start getting out of just responding to some sort of stimulus, they can actually be cognitive. Are they confused? Are they agitated? Are they confused, less agitated, but more inappropriate? Say some things that probably shouldn't have been said. And then eventually you get to where they're able to listen, obey commands, and do what's needed, and you can keep their attention for a full treatment session and beyond. And that's where you get to automatic appropriate and purposeful appropriate scales on the Ranchlos Amigos scale. So going over treatment for TBIs, treatment can range depending on how severe their TBI was and what stage are they in as far as recovery. If they're in a coma, then you're looking at trying to preserve range of motion, and so that would be looking at like serial casting, as well as making sure that they don't develop any pressure ulcers or anything like that. Giving them the adequate sensory stimulation, whether it's auditory, olfactory, all the senses. That way they have that stimulation, which will help as far as getting out of coma, but also as far as treatment going on forward past that. You have vibration, postural drainage, positioning, or bed mobility. You could do tilt tables. There's a lot of things that you can cover in the acute stage, whether they're in a coma or they're just getting some alert and orientation back. When you move from that to like active recovery, depending on how bad their TBI was and what parts of the brain is affected, whether it's lower extremity, upper extremity, one extremity versus the other, trunk, what kind of signs and symptoms are they presenting with, spasticity, rigidity, whether it's flaccid. That will all tailor what kind of treatment you provide, but treatments in that realm, you'll be looking at a lot of motor learning strategies, trying to learn how to move again with the extremities that they are able to move and move properly. Whether that's walking, whether that's trying to put your shoe on, your sock on, anything from there. You also have locomotion training, ambulation, trying to get them to walk. Constraint-induced therapy is another good one for TBIs as well for stroke. That's where the parts of the body that are affected, you're really trying to work on getting those to learn the movement and getting them to use those extremities to do movements instead of using the other extremities that were not affected, that they can move pretty well. You also have to keep in mind of aerobic and endurance training, because with a TBI, especially being in a hospital bed for a long time, they lose a lot of that fitness that they need to be able to move, especially with some parts of their body not able to work as efficiently as they did before. It's going to have a higher aerobic cost for movement in general. And then you could add other things in there, well, resistance training for sure, and then like electrical stimulation if needed, dual task performance, and then family education is very important, because depending on what level they return to, their family will have to be able to help them in the daily community with whatever deficits that they do have if they're not able to get past those with an ADL or through therapy in general.
All right, so I will be talking about Parkinson's disease. As far as the anatomy and pathophysiology, Parkinson's disease is a deterioration of the dopaminergic neurons in the substantia nigra that causes altered motor movements. So for anatomy, there are stimulatory and inhibitory pathways in the basal ganglia, the direct and indirect pathway. And these pathways are kind of checks for each other that allow for smooth and controlled movements. And then dopaminergic pathways help with the kind of enhancement of the contractions and allow for better contractions of the muscle. So when there is damage of the dopaminergic neurons, there is decreased stimulation of the motor cortex from the basal ganglia. So this is a problem because when there's decreased stimulation of the muscles, this is what causes bradykinesia. So they'll have that slow kind of shuffling gait and also problems with initiation of movement. And then so that affects the gait as well as their posture, because Parkinson's patients present with that hunched over kyphotic posture. Another reason for this is that there are cholinergic neurons in the basal ganglia, and these are responsible for having the opposite effect of dopamine. So anything that dopamine does, cholinergic neurons do the opposite. So normally you have a normal balance between acetylcholine released by the cholinergic neurons and dopamine. So you'll have a normal balance, but when you have that decreased dopamine, there's an unequal balance of checks from acetylcholine and dopamine. And this unequal balance will cause the resting tremors as well as rigidity. As far as etiology, there's no specific 100% known cause for Parkinson's disease, but there are a few theories. The main theory being that it's a genetic mutation on some specific genes. These genes include LRRK2, PARK2, DJ2, or also PINK1. There's also a theory that Parkinson's can be caused by toxins in the environment, such as insecticides that contain DDT. And then for diagnosis of Parkinson's, there's no one test or lab test that can be run to diagnose Parkinson's, but it's more on the clinician to look at the signs the patient is presenting with, and if they think that Parkinson's is a possibility after ruling out similar diseases, then they will put them on L-DOPA. And if this helps resolve symptoms, then it is known that it is Parkinson's. So as far as prognosis for people with Parkinson's doesn't directly affect the lifespan of someone with Parkinson's. So they have a normal prognosis of life, but it does create a greater amount of stress on the person as they go through life. So even though it doesn't decrease their lifespan, they will have more stress on their body going through life. And then as far as medications are the main form of treatment for Parkinson's. The main form of treatment is levodopa, also known as L-Dopa, but there are a few other medications that can be used, such as dopamine agonists and also anticholinergics to help with that balance of dopamine and acetylcholine in the basal ganglia. There can also be a surgery to implant a deep brain stimulator. And then as far as presentation, Parkinson's patients will present with tremors, primarily resting tremors, rigidity, so they'll have that resistance to movement in both upper and lower extremity, and then they'll have bradykinesia, meaning they'll have slow movement, also problems with initiation of movement, and then they'll also have postural instability, so they'll be presenting with that hunched over kyphotic posture. And that's Parkinson's. In scales, there's a few different ones. It's good for formulating treatment. For one, there's the Parkinson's disease questionnaire, and this is good at assessing overall quality of life for someone with Parkinson's. There's also the Han and Yar scale, which looks at severity of Parkinson's, and then the gold standard for assessing Parkinson's is the UPDRS, which we went over in class. It is the most widely used scale. It's a scale from 0 to 199. The lower the score, the less impairment, the higher, the more severe Parkinson's they have. Part 1 is just going over non-motor aspects of daily life. Part 2 is asking questions and rating motor aspects of daily life. And then part 3 is a motor examination of the patient. Example of the first part, talking about non-motor aspects of daily life, a question example would be like, over the past week, have you had uncomfortable feelings in your body like pain, aches, tingling, or cramps? And then they would rank that on a 0 being normal, none of that, to 4 severity, being severe, and then I would mark down the score. And then an example of the motor aspect of daily life, I would ask you questions such as, over the past week, have you usually had troubles handling your food and using eating utensils? For example, do you have trouble handling finger foods or using forks, knives, spoons, or chopsticks? And then they would rank that on 0 being normal or 4 being severe, and then that would go to add up to the total score. And then there's a motor exam part of this, and then so an example of this would be testing rigidity. So for rigidity, I'd just be moving him through passive movement and seeing how much rigidity I feel, and I would rank that on this 0 to 4 scale, 0 being normal, no rigidity, and 4 being marked rigidity. So I'd mark both upper extremities, and then I would also take him through passive movement of his lower extremity. So extending the hip and knee and flexing it as well, seeing how much resistance I'm getting through the movement. And then I would also go through some motor tasks such as pronation and supination. So I would have the patient hold your hand out, and I'd ask them to turn their hand up and down as fast as possible within 10 seconds or 10 times and see, and I would observe how easy the movement is, or if there's any slowed movement or stop movement, or if there's any tremors with the movement. And then I could also go through gait assessment. I could see how well he stands up from the chair. So for example, if we wanted to get up, I would see his movement as he gets up, And then I'd also go through a gait assessment, seeing how well he is able to walk, if there's any slowed movement, or if he has any trouble continuing walking. And those are the motor tasks that we would go through. All right, so with Parkinson's patient, regular exercise is very good for them. One of the things that is good treatment for them is strengthening as well as flexibility. This will help just maintain strength, flexibility of daily activities, as well as overall range of motion and mobility, and just overall better motor control. So when strengthening a Parkinson's patient, you want to focus on going through a full range of motion, a slow, controlled full range of motion. So for example, if I was wanting to strengthen biceps, I have them strengthening, going slowly through it and making sure they have that movement all the way through the full range of motion, and all the way back down, slow, controlled through that full range. And then also stretching is very important just to maintain the range of motion and mobility for everyday activities. And then another good aspect for Parkinson's patients is the LSVT BIG program, which just gets them moving big, because Parkinson's patients have those small movements. So it'd be good to use a mirror, so for that visual feedback, seeing how big they are moving, because they often move smaller than they actually are or think they're moving. So I'll have you get up, and a couple of examples for this would be, so I would want you to reach out with one arm and one leg as big as you can. And then it would be a good idea to have them rate how big do you think that movement was on 0 to 10 scale? 9. And then I would probably rate them myself and be like, that was a 5 out of 10. Can we try to get to 6 out of 10? And have them reach out as much as possible, as big as possible. And then that's why a mirror is a good example, because then they can see that they're not actually moving that big as compared to what he thinks he's moving at. Another example would be reach up and out as big as you can. And then I could have you rate that. How big do you think that movement was?
That was like 11.
And I'd be like, well, that's like a 3, so can we get to a 4 movement? And then that's a good way to progress this exercise or this program, is just generally increasing the movement and how big they think they're moving, and kind of going up that scale of how big the movement actually is. And then generally you can do the same thing with gait. Instead of having a shuffling gait where they're taking rapid small steps, I'd have them progress through the gait cycle with a full stride length. So for example, we'd work on gait, and he's taking those shuffle steps. So I'd have him probably have like a target here, and try to reach for this target here for your full step length. Good. And then reach out big with the next leg. And then I just have them do big emphasized movements to retrain that gait to have a normal kind of step length. And then another good aspect of therapy is just assessing the need for any sort of assistive device or modifying their environment to help cater to their disease. So, yeah.
I'm going to be talking about multiple sclerosis. It's also known as MS. It's an autoimmune disease that targets the central nervous system, and it's going to be a chronic disease. And the cause for multiple sclerosis is not known. So the anatomy and pathophysiology of MS. So you're going to have cells that are called macrophages and microglia that bind antigens to a target for an immune attack, which will be the myelin in the axons. And then these Macrophages and microglia are also called antigen-presenting cells. These cells form a complex with T cells to trigger a cascade of events which lead to the destruction of that myelin and the oligodendrocytes which produce the myelin and maintain the myelin, which the areas that are going to be affected that the myelin is going to be demyelinated are going to be called lesions or plaques. So MS is divided into 4 main presentation. So you're going to have relapsing remitting, which is episodes of acute worsening or of neurological function with some amount of recovery and no progression in between. Primarily progressive, which is continuing worsening of the disease without distinct relapse. Secondary progressive, which is relapsing remitting disease initially, and then eventually converting to a progressive form with a gradual loss of function. And then progressive relapsing, which is progressive disease with an onset with acute relapse and continuing disease progression. And so some symptoms that you will have during a relapse include double vision, numbness, tingling, slurred speech, limb weakness, clumsiness, imbalance, bowel and bladder symptoms, and these symptoms can completely resolve or one may remain with a partial deficit. So some additional symptoms common to these patients with MS include fatigue, heat intolerance, depression, and spasticity. So for the diagnosis of MS are going to be based on these clinical attacks that they're going to present with and MRI evidence. And so MRIs are going to be a valuable tool to establish an early diagnosis and also to monitor the disease progression. And then some other additional testing that might be done are lumbar punctures and visual evoked potentials. So 3 out of the 5 following criteria must be met to have MS. So 9 or more T2 hyperintensive lesions, 1 or more GD enhancing lesions, 3 or more lesions that are ovoid fingers oriented perpendicular to ventricle, 1 or more infratemporal lesions, especially of the MCP, and 1 or more spinal cord lesions, especially of ovoid and non-spacing and non-opposite areas of a spondylosis. And then the prognosis is good and bad. Although MS isn't fatal, there's currently no cure for MS, and it's a chronic condition like I mentioned earlier, and the lifespan for MS is about 7 years shorter than people who don't have MS, which isn't a whole lot. And then treatments include immunomodulating medications, steroids, and immunosuppressant therapy.
So today I'll be talking to you about the functional assessments and outcome tools that can be used for multiple sclerosis. So one of them is the Multiple Sclerosis Quality of Life instrument. And so it's this big packet. It's just a questionnaire that you'll have the patient fill out. And then there's also the Kurtursky Expanded Disability Status Scale, and you kind of rate them based on what you see with their disability. And for the sake of time, I will not be going over those, but I will be going over the Multiple Sclerosis Spasticity Scale, which is the MSS-88. So it's just a questionnaire that you're going to give to your patient to ask about spasticity and how it affects their life. So there's 8 sections, and so the first section is questions concerning muscle stiffness, and all of these questions are based on a scale 1 through 4, 1 being not bothered at all, 2 being a little bothered, 3 being moderately bothered, and 4 being extremely bothered. And so one question for muscle stiffness would be stiffness first thing in the morning. And then section 2 is pains and discomfort, so pain or uncomfortable spasms. Section 3 is concerning muscle spasms, so do spasms disturb your sleep? Section 4 is the effect of spasticity on daily activities, so putting on socks or shoes, getting in and out of the car, and sitting up in bed. And then section 5 is effects of spasticity on your ability to walk, being clumsy when walking, losing confidence when walking. Section 6 is spasticity on your body movements, so limited range of movement, difficulties bending your limbs. Section 7 is spasticity on your feelings. Do you feel frustrated, feeling less adequate, feeling angry? And then section 8 is the effects of spasticity on social functioning. So do you feel isolated, vulnerable, or feel less sociable? And so you'll just have them fill this out. And so all of these can be used to determine where they're at with their MS and can be used to measure after you do treatment with them to see how they're doing.
For PT treatment with MS, you really want to respect the patient
and their fatigue levels, as you don't want to aggravate them too much because this is going to be something that they're going to have to deal with, even if it's episodic. And so you want to just make goals that are going to be realistic and meaningful to the patient and what's going to give them the best quality of life. And so to do this, you're going to really want to educate both the patient and the family about MS and make sure that they kind of understand what they're getting into if this is new to them. If not, they probably know a little bit more about it than you do, honestly, but you can still educate them about the PT aspects that they may or may not be familiar with. And you want to promote their safe movement and promote independence as much as possible, and then provide resources and equipment to help them during their recovery or during an episode of MS. And then you want to train family and caregivers how to best treat them, especially if they are bedridden and you're having to work on transfers. And so a couple of goals or things that you might want to work on during physical therapy include ambulation and mobility, posture, trunk control, and like I said earlier, to work on those transfers and balance, and then range of motion. So they're going to have significant hip flexor, adductor hamstring, and heel cord tightness. They're going to have limited overhead motion because they're going to be in a hunched over position. So that's going to have tight pec minor and major and latissimus dorsi. And then they're also going to have poor head control. And these are going to depend and vary based on each individual patient, but those are most common seen in MS. And then you're also going to want to work on motor function and in some neurological functions. Some things that you might want to just be aware of with MS is that they will possibly have abnormal tone, clonus, tremors, coordination, issues with both fine and gross motor, and then sensation, proprioception, and pain. And then some considerations that you might want to look into as far as maybe trying to refer them out include speech, cognition, emotion, social, and vocation or homemaking. And so you just want to be aware of those things and see if maybe they also need to have some assistance from speech therapy or occupational therapy. And then some treatment plans and goals. So you just want to make sure that your goals for treatment are appropriate, attainable, functional, and consistent with what the patient wants out of PT. For a patient with MS, another possible, like I mentioned earlier, possible treatment plan includes range of motion. And so one of the exercises that you can have your patient do because they have tightness in their heel cords is doing a simple exercise at home where they put their toes on a wall and come up forward, or even a cabinet or anything that they can stretch back in the hamstring or gastroc and soleus area. And so this can be beneficial to just do daily for an MS patient.
On the topic of ALS, which also stands for amyotropic lateral sclerosis. The A means no or negative, myo means muscle, trophic means nourishment, and then lateral is referring to the specific area in the spinal cord where portions of the nerve cells and control cells are located. Sclerosis means scarring or hardening. So basically, it's the lack of nutrition to the muscles. For the pathophysiology, it's a degeneration. It's a terminal disease affecting the upper and lower motor neurons. For the lower motor neuron part, it's more focused on the anterior horn cells of the spinal cord and the motor cranial nerve nuclei in the brainstem. For the upper motor neuron section, it's the demyelination of the corticospinal and corticobulbar tracts, i.e. voluntary motor. So for etiology, right now there's no truly known source of the etiology of where ALS comes from, but there is theories when it comes to the genetic, toxic, abnormal levels of macronutrients. I can't even say the word. The deficiency in nerve growth factors, stuff like that. When it comes to the genetic side of things, they have found some form of links to chromosomes. For instance, chromosome 21 and chromosome 2 have been found to be linked to ALS. Now, for clinical presentation, it really depends on what nerves have been affected when it comes to the onset. For example, the lower limb onset, you'll see tripping, stumbling, awkwardness when walking or running. When it comes to the upper limb onset, you'll see difficulty with fine motor, such as like buttoning clothes or picking up small objects, turning keys. And there's also the bulbar presentation, which we'll have an example later on with my partner Hayden. It's speech problems, slurring, hoarseness, decreased volume, or even at times crying or laughing when you don't mean to. There's also when it comes to bulbar, it's the lower brainstem, which is the control of cranial nerves 7 and 12. The other clinical presentations you may see is there's also a cognitive side of things where people with ALS have been said to have behavioral deficiencies, and it's a progressive condition to where it's affecting the frontal and anterior temporal lobes, producing personality changes, language difficulty, and it's been said that 20-25% of ALS patients may have this type of cognitive effect. And then when it comes to upper motor neurons, you'll see weakness, increased reflexes, increased tone. For lower motor neurons, you'll see weakness, atrophy, fasciculations, and decreased reflexes and tone, unlike the upper motor neuron. When it comes to diagnosing, they use the LS-Goriel criteria, which you will get a little bit later. And then when it comes to the severity, they use the ALS functional rating scale, which I'll go over as well. But for other diagnosis, they use MRI, magnetic resonance of the neck, sometimes head and lower spine. They use EMG, which tests for nerve conduction, and serial blood tests. Some people use the urine test, genetic test, or a lumbar puncture for a spinal tap as well. When it comes to prognosis, it's a very sad prognosis. Most people die within 5 years of diagnosis. Only 8 to 22% survive at least 10 years. Its prevalence is not as bad. It's 1 to 2 cases per 100,000 people. Mean age onset is 57 years old, and 2/3 of them being between 50 and 70. When it comes to meds, there's 5 different meds. 4 of them are basically the same thing, but they're administered a little differently. So you have the very first ALS medication that came out in, I think, 1995, which is the Rilutek. It inhibits glutamate release, and it prolongs life only, sadly, 3 to 6 months. There's the Radicava, which is the newer one that has come out after 22 years, which it helps a slow decline of physical function by 33%. And then the other 3 are the same as Rilutek, but different administration. So you have Tegulitic, which is the thickened liquid form. So it's for those who have swallowing difficulties because now their muscles for swallowing has been affected. You have Exervan, which is a film which dissolves on the tongue. And then you have Nudexta, which is treating of the pseudobulbar effect. And to correct myself, in the past, the pseudobulbar effect is when they are laughing and crying when they don't mean to. So it's not the bulbar, but the pseudobulbar, meaning fake bulbar. So just to correct myself on that. Now, for when it comes to treatment, as I will go through, I just wanted to add one thing, is you also want to work on spinal stabilization to help maintain respiratory status, because once their lungs are affected, it's a quick decline from there and they'll have to be on a ventilator. The PT concerns I went over, and just also want to add equipment. Most ALS patients will get to the point where their necks will be too weak, and they won't be able to hold their head up, so they're going to probably need neck braces. And yeah, that's it. I'll be going over a diagnosis tool and scale to use for ALS patients. For diagnosis, they use the LS-Goriel criteria. There's 4 things in this criteria. Number 1, signs of degeneration of the lower motor neurons. 2, signs of degeneration of upper motor neurons. 3, progressive spread of signs within a region of or to other regions. And then the last one, the absence of any other pathological or neuro imaging evidence for something else that may be affecting it. So when it comes to the scale, they use the ALS functional rating scale. Of bulbar. Bulbar is when you're laughing or crying when you don't want to. So you might have that for ALS. But for the scale that we're going to use, they look at 10 different things. They have speech, they have salivation, swallowing, handwriting, cutting food, or if they're on a GI tube, them setting up their own GI tube, the dressing and hygiene, turning in bed, walking, climbing stairs, and breathing. So we'll only run through a couple just so you can get a gist of it. When it comes to speech, I'm looking at potential of how he responds, if he's slurring or if he has total loss of speech. Mind you, every one of these is scaled from 0 to 4. There's 10 items, so the top score is a 40. From 40, if you get a 40, that means you have mild. This isn't a diagnosis tool, so this is just seeing the severity. So 40 would still be mild because they were already diagnosed. 39 to 30 is moderate. Anything below 30 is severe ALS. So if I talk to him saying like, "Hello Hayden, how are you doing today?" Hello. So it was a little slower, but it was intelligible. I would probably put that as a 3. It wasn't normal. After salivation, if I'm looking to see if he's drooling at all, examples would be number 4 would be normal, there's no drooling. 3 would be slight but definite. 2 is moderately excessive. 1 is marked excessive, and 0 is they need to constantly be dabbing themselves to get rid of the saliva. And then another example would be, for instance, handwriting, looking at that. 4 would be normal. Number 3 would be it's slow or sloppy, not just saying he has bad handwriting, but you can see that this isn't his normal. It's really slow, it's sloppy, but it's still readable. But when it comes to the number 2, the one right below it, not all the words are legible. You're having trouble to figure out the words. 1 would be able to grip the pen, and then 0 would be not able to grip the pen at all. So this is the type of scale that we would use for seeing the severity of ALS, dependency. Another aspect when it comes to ALS is keeping in mind the psychological aspects. So part of the treatment is actually working through with them what to expect. It's gonna be really difficult, and the mortality rate is of course 100% when it comes to ALS, but it comes quickly, and so it's a very fast decline, and you need to also keep in mind their spiritual side, their psychological side, and even taking into family when it comes to counseling them on that and doing the end of life care with them. So that is what to do for treatment for ALS.